Picture a healthy young patient walking into the ER and suddenly collapsing. Their blood pressure bottoms out and their organs begin shutting down. They are in cardiogenic shock. The clinical signs all point to a massive heart attack. They have crushing chest pain, their EKG shows severe arrhythmias, and blood tests show sky-high troponin, a classic marker of cardiac muscle damage. But when doctors rush them to the cath lab to clear a suspected blockage, the angiogram shows completely pristine coronary arteries. There is no clot. The true culprit is acute fulminant myocarditis, a rapidly progressing inflammation of the heart muscle. Looking at this breakdown, we can see what separates standard acute myocarditis from the fulminant subtype. The fulminant differentiator is hemodynamic instability, leading to rapid cardiogenic shock. The mandatory criteria require mechanical or chemical support just to keep the patient's blood circulating. This distinction is a matter of life and death. If an ER team treats this like a standard heart attack and administers routine rate-controlling drugs like beta blockers, the patient could die instantly. The inflamed heart is simply too weak to tolerate any further slowing of its rhythm. At the microscopic level, the disease triggers a sudden, diffuse inflammatory response. The cardiac muscle cells rapidly swell with fluid and begin to die off in a process known as necrosis. Because the muscle tissue becomes so profoundly swollen and waterlogged with edema, the heart literally loses its mechanical ability to contract and pump blood. Without that pumping action, perfusion to the rest of the body plummets. Oxygen-rich blood stops reaching the brain, the liver, and the kidneys, initiating rapid multi-organ system failure. To save the patient, the medical team has to completely bypass the failing heart, artificially maintaining blood flow before the vital organs die from oxygen starvation. This chart maps the R2-ADC paradigm, the strict clinical blueprint required to keep these patients alive. It starts with 2 R's, rapid recognition of shock and immediately referring the patient to a tertiary hub. A stands for aggressive positioning of mechanical circulatory support. This process involves a technique called biventricular unloading. Machines use external tubes to actively siphon blood out of the failing ventricles and route it around the organ, taking over the physical work of pumping and drastically decreasing the stress on the inflamed tissue. As outlined in this management pathway, devices like VA ECMO or an Impella pump act as a temporary bridge to decision. They achieve the goal of perfusing the end organs, giving the exhausted heart muscle a chance to rest. These machines do not cure the underlying disease. They are strictly a mechanical bridge, buying the medical team a narrow window of time to identify the exact biological trigger attacking the heart. That brings us to B in the paradigm, a mandatory endomyocardial biopsy performed within 48 hours of admission. Doctors must extract a physical piece of the heart tissue for analysis. This diagram shows why guessing pathology is dangerous. Physicians must match exact biopsy results to specific therapies. A general lymphocytic presentation calls for empirical steroids, while an eosinophilic presentation requires anticoagulation. Finally, step C requires targeted immunosuppression, critical for a highly lethal subtype, giant cell myocarditis. This slide shows giant cell myocarditis under a microscope, with characteristic multinucleated giant cells destroying the tissue. The graph on the right tells the rest of the story. Without immediate targeted immunosuppression using drugs like cyclosporin, the outcome is almost universally fatal within a year. Precise differentiation of the cellular subtype is the only way to deploy the correct chemical weapon, stopping the immune system from tearing the heart apart. If the medical team successfully bridges the patient through initial shock using machines and targeted drugs, a strange statistical anomaly emerges in the recovery data. This graph illustrates the prognostic paradox of acute fulminant myocarditis. At diagnosis, the red line shows fulminant myocarditis has a massive acute mortality rate compared to non-fulminant cases. The initial drop is steep and brutal. But look at where the lines cross. If fulminant patients survive the initial shock with mechanical support, their long-term trajectory stabilizes. They actually achieve significantly better long-term functional recovery than the non-fulminant patients. This happens because the violently lethal inflammation that almost killed the patient was in fact a highly robust immune response. Once the acute phase is managed, that same aggressive immune system does an exceptional job of clearing the underlying virus. Still, returning to normal life requires strict adherence to healing protocols. Patients must absolutely abstain from any sports or intense physical activity for 3 to 6 months to allow the myocardial tissue to fully repair itself. Fulminant myocarditis is an illness of fast-moving extremes. By utilizing aggressive mechanical support to buy time and precise biopsy-guided therapy to stop the inflammation, doctors can give the human heart the exact conditions it needs to demonstrate its